Okay, I think we'll go ahead and get started. My name is Chris Spurney. I'm in the Division of Cardiology. I want to welcome all of you to the 25th annual Garbose lecture today. This lectureship is supported by the Garbose family in honor of their daughter, Emily Cara Garbose. She unfortunately had a very rare genetic defect, the pathology of Cantrell, which includes congenital heart disease. In this case, she had tetralogy of Fallot. It also includes sternal defects, and so she had ectopia cordis, where the heart is actually outside of the chest wall. And 20-some years ago, because of these defects, she did not survive very long. And since then, the family has supported in fetal research and pediatric cardiology, and this lectureship is one of the ways that they chose to honor their daughter and remain committed to congenital heart research here at Children's National. So we appreciate their support. I'll have Dr. Jonas come up to introduce our speaker today.
Well, thanks, Chris. Welcome, everybody. It's truly a great honor to introduce Dr. Jim Tweddell, who's our Garbose lecturer for this year. Jim is a good friend and for many years has been truly one of the outstanding congenital heart surgeons, not just in this country, but in the world. He has really quite a remarkable CV. So Jim is originally from Cincinnati, Ohio. He went to medical school in Cincinnati. He began his general surgical training in New York at NYU. And then he moved to Washington University, St. Louis. And at the time, WashU and really since, WashU was really an incubator for a remarkable series of cardiac surgeons, cardiothoracic surgeons. I believe WashU has more presidents of the two major national cardiothoracic organizations than any other program in the country. Jim had the opportunity there to work with Dr. Jim Cox, who was really a renowned innovator and brought together an amazing team, including Dr. Tom Spray, who's been the chief of cardiothoracic surgery at Children's Hospital of Philadelphia for about the last 20 years or so. So Jim, not surprisingly, got attracted into cardiothoracic surgery at WashU, trained there, and then he went off to Milwaukee, Wisconsin, a relatively smaller center where he established really the leading program in the country at the time for the management of hypoplastic left heart syndrome. So Bill Nord had pioneered the Nord operation at Boston Children's, but in its early years, the Nord operation really had an exceedingly high mortality risk. And Jim showed that by bringing together an outstanding team of people, including anesthesia, intensivists, cardiologists, as well as, most importantly, managing these babies once they went home, because there used to be a lot of mortality between the first stage Nord operation and when kids would come back for their second stage bidirectional Glenn operation after about 5 or 6 months. And by setting up a home monitoring program where families would call in or bring their babies in either on a weekly or even a daily basis, he was able to pretty much eliminate that interstage mortality. So he's a remarkable clinical surgeon. He's excelled in all other areas of the academic cardiothoracic surgeon as well. He's really been remarkably well funded. He's currently the principal investigator for the pumpkin trial, and I'm sure we're going to hear a little bit about advances that are happening in ventricular assist devices for children. So there's a multi-institutional study of a miniaturized ventricular assist device that is about to undergo this major clinical trial. And in the public service area, which is really can be really selfless undertaking, being a representative on committees for major national organizations. Jim has every major organization covered. He's been secretary of the Congenital Heart Surgeons Society, a very important role for us congenital surgeons, but also for the major cardiothoracic organizations that represent all chest surgeons throughout the country, adult, lung surgeons, and as well as pediatric surgeons. He's been on numerous committees and played extremely important roles. And of course, he's trained numerous young surgeons. One of our young graduates from Boston Children's, Mike Mitchell, came under his mentorship and has really flourished in Milwaukee. And just 2 years ago, Jim decided to take on the next challenge and complete the circle and head back to Cincinnati, where he is running one of the country's great programs at a great pediatric hospital. So it is indeed an honor to introduce Jim. Jim's going to be talking to us about advances that have been occurring in the field of neonatal surgery. And Jim, we look forward to hearing your Garbose lecture. Thank you.
Thank you, Richard. That was a very nice introduction. And it is a real honor and a privilege to be here to speak to you today. I'm going to talk about advances in neonatal cardiac surgery. I decided to sort of organize this based on recent advances, things that I think should be relatively easy for us to do, the low-hanging fruit, what I think is on the horizon, and then I will have the temerity to suggest what might be the next moonshot for our subspecialty. I do have a couple of disclosures, and I will be mentioning both core matrix as well as some agents from Ionis Pharmaceuticals that we've done some work on recently. I'm going to give you a brief history of neonatal cardiac surgery. This is a paper that Ed Beauvais wrote, I think, when he was a senior registrar at Great Ormond Street. And it summarizes the state of the art of neonatal heart surgery in the late 1970s. He reviewed 212 neonates undergoing cardiac surgery over a 4-year period. 40 of these had open heart surgery, so 40 patients over a 4-year period. That's 10 neonates a year at probably one of the leading cardiac surgery centers in the world. And the mortality for those 40 patients was 57%. So I think this, although they had a fairly optimistic conclusion in this paper, I think you can see that in the 70s, neonatal cardiac surgery was generally something that most people try to avoid. And in particular, you can see here the operations that were done. Total anomalous pulmonary venous connection was the most common. Obviously, these were neonates that could not wait, could not be palliated in any way, and they had a high mortality, about where did I find that? Complete 50%. Indeed, only pulmonary valvotomy, which we don't do surgically anymore, the mustard operation really had mortalities that were 50% or less. So it was a particularly challenging group of patients. The big change came with this lesion, transposition. So this is the normal heart here, the right ventricle pumping blood to the pulmonary artery. But in transposition, the right ventricle is connected to the aorta and the left ventricle to the pulmonary artery. And what the transformative change here came originally from South America, from Brazil, when Gittini and colleagues performed the first arterial switch operation. The first patients were actually not neonates, they were infants, and they had a large ventricular septal defect. But pretty soon, this operation was being adapted to neonates. And you can see here, this is the title page from a paper in 1984, which includes Dr. Jonas. He's one of the pioneers of neonatal cardiac surgery, which I'm sure you all know. And what they did is they applied this operation to neonates, and this was their first report of a series of neonates undergoing the arterial switch operation. And that looks something like this. The great arteries were divided, the coronary arteries were transferred above the semilunar valves, and then the great vessels were reattached in order to realign the right ventricle with the pulmonary artery and the left ventricle with the aorta. I would say that this is probably marks the real beginning of neonatal cardiac surgery in earnest. You had a diagnosis for which a neonatal operation achieved the best possible long-term outcomes that occurred with enough frequency that you could actually establish cardiac surgery centers. And pretty quickly, this was the operation that really defined the congenital heart surgeon. In the 90s, when I was looking for gainful employment, if this was the operation you had to be able to do in order to find a position. Now, there were certainly there was some learning curve as the world progressed from the atrial level switch to the arterial level switch. Nonetheless, this became very well established. And again, I think this probably marks the beginning of neonatal surgery in earnest. One of my mentors in medical school, Warren Bailey, knew that this was on the horizon and actually trained in pediatrics for a couple of years so that he would know how to take care of newborns in the postoperative period, and then went on and pursued heart surgery training. Then we turned our attention to this lesion, and this was a very different animal indeed. This is hypoplastic left heart syndrome, and you can see here a very underdeveloped left ventricle, an atretic aortic valve, and really the right ventricle in this case is the workhorse of the circulation, and systemic circulation can be maintained via patent ductus as long as that is either opened or maintained. And it was, again, in the early 80s when this was when the first successful surgical treatment for hypoplastic left heart syndrome was described by Bill Norwood. And this is the operation that was described in that paper. So here we have the single right ventricle tiny ascending aorta, the right ventricle giving rise to the pulmonary artery, the descending aorta, basically a continuation of the ductus. He isolated the pulmonary arteries from the aorta, and then anastomosed the pulmonary route to the ascending aorta and arch to provide unobstructed systemic outflow. This is the more commonly recognized operation that really marked the first years of the Norwood operation. Again, a connection between the diminutive aorta and the aortic arch, and then creation of a shunt from the innominate artery to the pulmonary artery. Today, there are three options for the newborn with hypoplastic left heart syndrome. The Norwood procedure, which I showed you in the previous slide, where the pulmonary blood flow is supplied by a Blalock-Taussig shunt from the innominate artery to the pulmonary artery. The RV to PA conduit, in which a Gore-Tex graft from the right ventricle to the pulmonary arteries is used for pulmonary blood flow. And then more recently, the hybrid operation, in which the branch pulmonary arteries are banded individually. The ductus is maintained with a stent, and an atrial septal defect is created as well. This ultimately leads to, if successful, bidirectional Glenn shunt, and then a completion Fontan. And now all the blue blood returning from the systemic venous system is routed to the pulmonary arteries first in order to obtain oxygen and give up carbon dioxide, returns to the single ventricle to pump that red blood of the body. And this is achieving as close to a normalized circulation as we can with patients with hypoplastic left heart syndrome. And I would say that these are some of the recent advances, and some of them I think are probably advances, and potentially some are not so much advances. That's why I've used Trump-like quotation marks here, so you'll have to interpret this in retrospect, I guess. But we've definitely seen improvements in perioperative management, improvements in interstage management, and then there are some other strategies which we still discuss at meetings on occasion: antegrade cerebral perfusion, whether the RV to PA conduit is superior to the blalotoxic shunt, and whether the role of the hybrid procedure. And we discuss all of these, and they are sources of much debate and fill up podium time at conferences, our surgical conferences. But the reality is there is significant room for improvement. This is data from the Congenital Heart Surgeons Society. This is comparing, this is a prospective inception cohort study comparing the right ventricular to pulmonary artery conduit Norwood, that's this line here, the RV to PA conduit, with the blalotoxic shunt. And the point of this paper was that in this slightly more recent than the SBR trial cohort, that the RV to PA conduit seems to be a little bit better. But I guess what strikes me is that here at 6 years, the survival is really still pretty poor overall, 50 to 60%. And this is a bit, I think, should concern us. And this has been identified in other studies as well. And in particular, the hybrid procedure really doesn't fare any better than these. And this is the most recent summation of the SBR trial. This was a randomized controlled trial that ended in 2008, comparing the RV to PA conduit with the blalotoxic shunt. And again, at 9 years, a little over half of the BT shunt patients are alive, really not much better with the RV to PA conduit. So we have plenty of room to do better with this. Well, I think this is the part of the problem here. This is data from the PC4, collaborative of centers. This is the in-hospital mortality for the Norwood procedure for the last 24 months among the 25 centers that participate. And you can see here wide variation in the hospital mortality. And also duration of mechanical ventilation. In some programs, patients, and these aren't the same programs, they're just listed in ascending order, but in some programs, the median length of mechanical ventilation is over 2 weeks after a Norwood procedure. Again, pretty significant, and a wide variation in outcome. Here's complications by center, and if anybody ever has a Norwood that has a completely uncomplicated postoperative course, I'd like to meet them because I don't think they ever do. And this is the PC4 data suggests that. But there's a significant risk of complication and a high variability. And not only that, but there's a significant difference in center variation in cost and length of stay, and neurodevelopmental outcome. So not only are centers doing very differently in terms of mortality, but even among the survivors, the survivorship is very different. And to me, this really suggests that we need a different strategy. And that's what I would say here is the low-hanging fruit and the potential for collaborative learning. That is a quality improvement strategy that takes into account that there's a great deal we can learn from each other. Two big examples of this were the New England Collaborative and the Michigan Blue Cross Blue Shield Collaborative. And the Northern New England Collaborative is really an interesting story because this was really practitioner originated. And they would basically, the adult cardiac surgeons would get in a minivan and drive and visit other programs and review their outcomes and see how they did things. And they would go to smaller programs, underperforming programs, programs that did better with things, and so on. And they had a rapid improvement in survivorship of the coronary bypass grafting operation, as well as a decrease in cost and variation. At first, it was sort of hard to put their finger on exactly what it was that they were getting out of this, but they all learned things from the different programs. So even a program that's relatively small or maybe didn't have the volume or the outcomes of other programs, they would sometimes be identified as doing something better than somebody else, potentially the handoff or the postoperative care or management of low cardiac output syndrome, which was quickly identified as the leading cause of death. So at first, it was the strategies for quality improvement were basically just going and watching what other people did and how they did it, and that was very effective. The New England, in Michigan, the heart surgeons there actually were able to get Blue Cross and Blue Shield to chip into this. And the Northern New England Collaborative, they ultimately got administrative support for the database and so on, but at first it was really more of a grassroots effort. The National Pediatric Quality Improvement Collaborative was initiated by this group pictured here, and I know Gerard Martin is there, and I wanted to make sure I recognized him as one of the important originators of this idea. Obviously, we can't all just get in a Dodge Caravan and drive to the next congenital heart surgery center because you could be driving for a day and a half to get to somebody who in a similar program. So we had to develop a little bit more of a strategic approach in pediatrics. But I think this is really an example of how that can work. These are the programs that are involved in the National Pediatric Quality Improvement Collaborative. And the first focus was on hypoplastic left heart syndrome and interstage survival. And some of the strategies that have been pioneered by my colleagues in Milwaukee were applied and disseminated to groups across the country. This was, again, this is potentially the first-year lifespan of a patient with hypoplastic left heart syndrome and the hurdles they have to overcome. But phase one of the NPC-QIC focused on this interstage period and identified some strategies that might improve outcome. This shows you the attendance of these learning sessions that began in 2010 and who attended. And interestingly, what we have seen is that patients and parents have started to become real partners in this strategy. And it's interesting as the parents began to show up. At first, it seemed to make the clinicians a little bit uncomfortable, which was kind of interesting. But ultimately, they've let us know what their concerns and what their goals are as well. And I think this has really brought things into focus for all of us that have been participating in this. And this really shows the impact of the NPC-QIC on interstage mortality. Here's the first collection of data in 2010. And what they were able to demonstrate is that that the collaborative was able to reduce interstage mortality by 40%, and it is now stable at about 5%. And again, this does represent a very high-risk period for a patient with hypoplastic left heart syndrome. So I think this is a real example of the power of quality improvement collaboratives. We have moved on to phase two now, and this may be drinking from the fire hose a little bit. So instead of just focusing on the interstage period, which I think was a nice package to start with. It was well-defined. You had to survive the Norwood procedure, and we were worried about you getting to the bidirectional Glenn shunt. And there was a lot to be learned there, and it was small enough, I think, that it was manageable. Now, we're going to be, we've really set a huge goal for ourselves, which is to improve outcome from diagnosis in the first year of life. And this is the phase 2. So this will include the hospitalization, as well as the hospitalization for the Glenn operation, and then ultimately survivorship to that first birthday. We have, as a consequence of this, we have identified these areas: optimize fetal and perinatal management, improve mortality, morbidity, and family support during the perioperative period, maintain and improve the outcomes of the interstage, work on neurodevelopmental outcomes, and ensuring parent and family support. We had our last learning session in Cincinnati in May, and this was mostly attended by cardiologists, but we are recruiting new team members, including intensive care, surgeons, perfusionists, fetal cardiologists, and developmental pediatricians. We had a breakout session, and we did have a number of perfusionists and anesthesiologists and a few surgeons there. And what became apparent immediately was the wide variation in practice among surgeons. We identified 3 perfusion strategies. Classically, this operation was done using deep hypothermic circulatory arrest almost exclusively, and then antegrade cerebral perfusion was adopted, and now is either alone or in combination with hypothermic circulatory arrest is a predominant support strategy on bypass. But there are also a number of programs that are doing this using continuous warm perfusion. So those are the 3 things, and it was interesting to hear the different perspectives of those strategies. And rather than sort of meet at a meeting and have podium presentations and brief discussions and so on, this allows for the perfusionists, anesthesiologists, and surgeons to sort of sit together and sort of discuss all of this. And among the new members of this effort, I would say that the enthusiasm among the perfusion team has really been incredible. They have been invited via their professional organizations and filling up my inboxes with enthusiastic yes responses. And I will say that perfusionists are a remarkable profession, and they take their jobs very seriously, and they're very committed to the patients, and they don't often share the limelight. So I think they're a good group to entrust with some quality improvement, because they are, it is all for them, it is about making the lives of their patients better. So I'm excited about their joining our effort, and I would welcome everybody to come to the next learning session, which will be in October, on the Saturday before the beginning of the Congenital Heart Surgeons Society. For the next several years, we've decided to try to interlink these 2 efforts to try to get more surgeons to come. So the Congenital Heart Surgeons Society typically takes place on a Sunday and Monday. This will, the learning session will take place on a Friday and Saturday, and we'll have an opportunity to co-mingle on that weekend. And so, invite your surgeons and perfusionists and anesthesiologists and critical care people to come and take part in this. What is on the horizon? Well, we still have a number of challenges in congenital heart surgery, but I would say one is better anticoagulation for mechanical circulatory support. I apologize for showing you the Clotting Cascade. I'm sure most of you have been happy to forget this. But this is the humoral factors involved in clot formation. For any time you injure yourself, it is really the tissue factor pathway that is at work. The contact activation pathway is the one that we identify as a consequence of cardiopulmonary bypass. When blood comes into contact with foreign surfaces, particularly negatively charged surfaces, the contact activation pathway is initiated via factor 12. But this is the pathway that we deal with for most injuries, and tissue factor ultimately activates thrombin. And importantly, thrombin has a self-regulatory component. It back activates factor 11 to positively feed forward its activation. And this works very well in a local injury environment, but not particularly well in a global situation. We use heparin to prevent clotting. Heparin impacts these factors, and And heparin is very effective at preventing fibrin formation on bypass, but it is associated with, as anybody who uses it will know, with bleeding. Well, could there potentially be a way to anticoagulate without increasing the risk of bleeding? And that sounds almost paradoxical, but there may be an option to do that. So if we could inhibit the contact activation pathway, isolate that, we would still be able to depend on the tissue factor pathway for local hemostasis and use it as it was intended. Factor 12 is sort of the beginning of the contact activation pathway, a Hegeman factor. It activates the coagulation system. It also activates the inflammatory cascade. So inhibiting factor 12 may have some real benefit. And there is plenty of contact in our bypass machine. This is a typical pump. And this is the hollow fiber oxygenator. Gas flows through the hollow fibers, blood pours over the outside of the fibers. You can see there's just tremendous surface area here in this artificial lung. There is some suggestion that factor 12 inhibition may be useful in extracorporeal circulation. This was a study using monoclonal antibodies directed at factor 12 from the Karolinska Institute. They used a rabbit model of ECMO, and they had three groups, a saline control heparin and this monoclonal antibody directed at factor 12. These what look like bamboo lampshades here are actually the microtubules bound together in the oxygenator. And you can see if you don't use any heparin, any anticoagulation, you get a lot of fibrin. That's what this looks like, this dirt here. If you use heparin, relatively little fibrin deposition, and a similar picture if you use the monoclonal antibody against factor 12. And this shows you the attempt to quantify the fibrin deposition, the saline heparin, and the factor 12 antibody. But what's very interesting about this is that if you look at the bleeding time, as you would anticipate, not anticoagulating, the bleeding time doesn't change very much, and heparin prolongs the bleeding time extraordinarily. But the factor 12 antibody did not impair bleeding time much, and it allowed the tissue factor pathway and typical platelet activation pathway to work unimpeded. We are looking at an antisense oligonucleotide, or a Gapmer. And a Gapmer is a small piece of oligonucleotides that are antisense to a messenger RNA of a protein that you would like to get rid of or suppress. And what happens is that the little antisense oligonucleotide gets taken up by an endothelial cell, and then it will block the RNA that you've chosen, and that will prevent the gene from developing into a protein, and this is called gene silencing. This is a paper from the New England Journal. They looked at, this is a randomized controlled trial. This was from the unfortunately named ISIS Pharmaceutical Company. So I'm collaborating with ISIS, but they've changed their name now to Ionis. I don't know why. And they did a randomized controlled trial of 300 patients undergoing elective knee replacement surgery, and they looked at this factor 11, so one step down from factor 12. And they treated them with factor 11 Gapmer, and gave them a couple of injections of this agent a little bit before their knee surgery. And factor 11 deficiency is associated with a little bit of coagulopathy. We'll bleed a little bit with this, but they actually showed that that factor 12 in 300 patients was superior to low molecular weight heparin, less venous thrombosis, and no increase in bleeding. The other thing about the Gapmer is that you can dial it in, so you can suppress factor 11 or any of these things as much as you'd like, either take it away completely or just a little bit. So it may be a way to sort of fine-tune the coagulation system. This is my colleague here, Joe Palumbo, in hematology, and we are using a rabbit model as well. We have three groups. We're using an ASO Gapmer without heparin, and then non-heparinized. And you can see here, this is protein electrophoresis. Control animal, this is factor 12 now, and they express this very well. But our donor rabbits, and for rabbit bypass, you need some donors. So, and they have to be factor 12 deficient as well, and we're going to test that. So all of the animals showed a complete suppression of factor 12. These are some of our early results. These are control animals. This is the pressure gradient across the oxygenator. So typically the pressure gradient across the oxygenator is vanishingly low. They're very efficient, and this is time. So this indicates oxygenator failure as the pressure starts to rise. This is because there's clot forming in the oxygenator and blood can't flow through there very easily. So these are our control animals. And down here, these are actually two superimposed curves, the factor 12 and the standard heparinization. Just a few animals so far, but I think we are going to be able to reproduce the results with the monoclonal antibody. And the nice thing about this is potentially long-term. So all you have to do is keep redosing this with periodic injections, and you can keep suppressing the whatever gene you want to target. And it's not just factor 12 that you can potentially impact, but factor 11, and there's a high molecular weight kallikrein inhibitor as well. So we might be able to really suppress the inflammatory response and really change how we take care of patients on mechanical circulatory support, whether it's bypass or not. This is Anthony Chan, who I had a chance to meet when I was with John Cultman during a group that met to discuss anticoagulation. He was at the University of Toronto working with Colleen Grunwald. He's now at McMaster University. He's looking at this thing, which is, so right now we give heparin and we depend on your intrinsic antithrombin to accelerate. The heparin accelerates the antithrombin's ability to inhibit all of those factors I showed you before. But maybe we should just cut out the middleman. In this case, he binds the heparin with antithrombin, and this has several potential benefits. Very long half-life. It really is great at inhibiting thrombin because of the high pentasaccharide content. This is the part of the heparin molecule that's really important. And it also inhibits fibrin-bound thrombin, which circulating heparin does not do. And it can be completely reversed with protamine because of all the high molecular weight subspecies. And this just shows you thrombin formation on bypass in a pig model. And this is something that, although we give heparin to suppress thrombin formation, we never completely suppress it. But the antithrombin heparin covalently bound one, this is the open circles here, has the least thrombin generation on bypass, either compared to unfractionated heparin alone or unfractionated heparin combined with an additional dose of antithrombin. So some real potential here, and importantly, the number of microemboli detected post-operatively is much less in the patients with the covalent antithrombin heparin combination. What is the next moonshot? Well, I don't know, but this is my suggestion is that maybe the success of cellular regenerative therapy. This was a case report published in 2015 by the group in the Mayo Clinic. Tim Nelson was a medical student at the Medical College of Wisconsin, and I had the opportunity to try to teach him a thing or two, but obviously he was much smarter than I was. So he went to the Mayo Clinic and joined with the Wannick family to develop stem cell therapy. They used umbilical stem cells. Here's a baby with hypoplastic left heart syndrome just before the bidirectional Glenn operation. You can see, you don't have to be a cardiologist to see this function is not very good. The heart does not squeeze particularly well. After the Glenn and after stem cell injection, you can see the function has improved dramatically. And there are a few more examples of these kids out there, and they've actually begun a clinical study on this. And then the group from Okayama has been looking at this as well. They're using a slightly different cell therapy, cardiospheres, and they are injecting these at stage 2 and stage 3. And you can see here in this randomized controlled trial that the patients who are receiving the cardiospheres have an improvement in their ejection fraction. And it's not just at the stage 2 where there is a significant reduction in volume of the ventricle, and you might expect some positive remodeling here, but also at stage 3. Obviously, consenting people to be in the group that isn't benefited would be very challenging here. So they went ahead, and after they followed them up for a period of 3 months, they did the same thing with the control patients, and they also benefited from even late stem cell therapy. This is a very interesting area. The stem cells themselves, regardless of what cell preparation you use, it's unclear that they spend much time in the myocardium. They don't seem to survive. They don't develop into cardiomyocytes. The source of the new myocytes, which are vanishingly small, seem to be coming from the myocytes that are already there. This is all well established, and and I wrote an editorial explaining all of this. It was, I thought, very insightful. But you know, the data is the data, and it's hard to deny this. And there's increasing work like this out there. And although at this point it may be a relatively shotgun blast, non-specific approach, if there is some benefit, it's certainly something worth pursuing. And we might ultimately identify what the agents are in this that may actually be doing the work, what the agents of the paracrine effect are, whether it's endothelial growth factor, what have you. But in the meantime, I think this is certainly looks positive. And if I were a child, if I were the parent of a child with an ejection fraction shown in that first figure, I would certainly want to give the stem cell therapy a try. And in medicine, we've had many medicines where we didn't know how it worked, but we gave it anyway. We still use plenty of those. This is another area where I think we may see some improvement long-term, and now this is using core matrix, and so I'll acknowledge the conflict of interest there. This is from Cincinnati, work done in Cincinnati by David Morales and Farhan Safar. Farhan is a researcher in our laboratory there, and he began looking at this tubular valve using core matrix. The idea here is that normal heart valves begin as delamination from the wall of the ventricle, so potentially somewhat a tube begin as a tube, and then ultimately they go on to develop into a well-developed mature valve. This is core matrix, which is small intestinal submucosa. It's basically a sausage casing. I think it was originally identified as having unique qualities at the University of Kansas, and they have been working on this for decades now to try to identify potential uses. But Farhan looked at a growing sheep model, and the valves were implanted in a tricuspid position. There was a control animal with a bioprosthetic valve as well, just to prove that that doesn't grow. That shouldn't be any surprise. But as the animals grew, the valves also increased in dimension. This is one of the valves in explant about 8 months after it was installed. You can be hard-pressed looking at that to say that that wasn't actually a tricuspid valve. That is a pretty impressive looking remodeling of this material. And remember, the valve is completely excised, so all of that is this remodeling of this sub-IS material. And this is pictures of the valve, and you can see what almost look like subvalvular apparatus trying to form. You can see the sutures here were sewn in place, but almost look like chordae. And this is the remodeling of the material over time. So here's the native valve showing you the different layers, and here is the small bowel intestinal submucosa at 3 months, and it doesn't look like much, but then at 8 months you can see that there has been remodeling that does imitate in some ways the native valve. And this is an 8 months an MRI of the valve in place, and you can see how that works very well. There's a little bit of regurgitation, but compared to not having a valve or at all, certainly much better. And there have been human studies. There's a couple of case reports in children that are coming out, and this may hold some promise for the future. Predictions about the future are tough, as Yogi Berra, the great baseball philosopher, said. You know, it's pretty common that our perceptions of the future are overly optimistic. You know, we were, by this time, when I was a kid growing up, by 2017, we were certainly going to have flying cars. And although we've had flying cars, they're not nearly as functional as the Jetsons. And I don't know what the next transformative change will be. This is a paper from a journal, the Archives of Dermatology and Syphilology, almost 100 years ago now. And this is a paper, a review on laboratory and clinical studies on intravenous injections of arsenamine and neo-arsenamine. And these were organic arsenic compounds that were used to treat syphilis in the 1910, 1920s. And this was a very well-organized paper reviewing all of the ways this could be done, the challenges with the agents because they were unstable in air and they had side effects and so on, but they offered these patients some hope. Obviously, this immediately evaporated once penicillin was discovered, and the journal changed its name. You can't find this journal. It's the Archives of Dermatology now. But it just goes to show you that sometimes it's hard to know where the next transformative change will come from. But I think we're going to see some things, hopefully perhaps some of the things I share with you today, that might ultimately make a difference and be part of our future care for neonates needing cardiac surgery. I want to thank you for the opportunity to speak with you today. I'd be happy to take any questions.
Before we take questions, just to let you know, there'll be a brief reception with Dr. Tweddell on the West Main 5th floor boardroom. So please come on by after the lecture. Dr. Tweddell. Go ahead and take some questions. Sure.
Thank you, Dr. Tweddell. That was really most engaging. The cardiac progenitor cells, I was a little unclear on actually how those are administered. Are they injected directly into the myocardium? One of the titles seemed to reference intracoronary injection. How do they get to the heart?
Yeah, that's a great question. So I'm sorry, I should have mentioned that. So the group in the Mayo Clinic is using intramyocardial injection. They actually inject the umbilically derived stem cells directly into the myocardium. Originally, we're going to use this exclusively in patients who had the sono modification. So there was an area of damaged myocardium. When they came for their second stage, that conduit is removed from the right ventricle, and that area is either repaired or the conduit's tied off, and they would inject this in the area of the scar. They have done some patients that have had a BT shunt with decreased function and shown also a dramatic improvement in the ejection fraction. The group in Japan is using intracoronary injection. So different. I mean, I think the intracoronary injection seems to, plausibly make more sense. Unfortunately, the cells don't always stop in the heart. You can inject them in the coronaries and they just fly right through onto who knows where, where they might go and set up shop. So maybe the direct injection gets you more progenitor cells where you want them. I don't know. Those are the two different routes that I'm aware of.
Great talk, Jim, and we really enjoyed it, and nice crowd. I'm going to go back to the beginning of your lecture. You sort of talked about the history, and I was struck by something you said about the learning curve for surgeons as they learn new techniques. And these days in the 21st century, it's almost not acceptable anymore to have a learning curve. So how do you deal with surgeons learning new techniques and avoiding the mortality and morbidity associated with that?
No, I think you're right. The idea of a learning curve, which is very well recognized in medicine and medical training, is not really well understood by the public. and I don't think would be well accepted, any more than we would accept a young pilot having a learning curve. Well, he crashed one, but you'd expect that because he's young. So that's just, we tolerate it. I think we're, in the age of, I think that all sort of goes back to I would say that probably goes back to the Libby Zion case. Suddenly the idea of people learning through trial and error on the uninsured or the otherwise is just not going to be acceptable anymore. And I think what's going to be required is a more prolonged mentorship approach. And I think that's from a de facto standpoint, that's what's happening. And I think we have to recognize that right off the bat. I think unfortunately sometimes we get new young faculty, they join our program. Sometimes we give them a little too much rope at first, and I think it's much easier, although you might be viewed as sort of hovering over them and watching their every move. I think that's probably a better than having individuals have a less than stellar track record starting out. So I think we're going to need a prolonged period of sort of training and a graduated approach. But at the same time, we can't really delay social and economic maturation of our trainees anymore either. They can't continue to train at a stipend level wage into their 40s. But those are huge questions, and I think we're going to have to figure out how to bring them on in a more stepwise approach. And Dr. Jonas has some thoughts about this as well, and I'd like to hear what his thoughts are to answer your question.
Well, actually, I was just about to wind it up. No, I mean, I do think that's one of the huge challenges. And there are many challenges in terms of the supply of young heart surgeons. I mean, it's about 50% of the training positions in cardiothoracic surgery for nearly 10 years now have been unfilled. So the number of people coming into the field really does make it increasingly difficult for us to really produce young surgeons who are able to step straight into undertaking complex neonatal surgery. So I don't think there's any easy answer. But I do want to thank you very much for an absolutely beautiful overview of this very challenging field. It's really been an exciting ride for the last 30 years or so, because that's really how long the field has been. It really just goes back about 30 years. So thank you for a beautiful overview and for a glimpse into the future and the next moonshot. It's been a pleasure to have you here.
Thank you.